Well, welcome back. Now we're going to get back to part two, picking up where we left off, talking about these two people on this one medication, and by coincidence I started noticing that they had certain excesses in their labs, and I started digging deeper and deeper and found out it's a really interesting story. So part one just happened a few days ago. This is part two, and we'll come to a rather surprising conclusion. Initially, when I started all this, I said, you know, the surprising conclusion is not so much that I discovered a lot of things in the labs, of their labs, that had a lot of commonality. Two people that didn't know each other, didn't live together, don't live in the same part of the country, reasonably close in age, a year apart. And this happened to be before and after about 1.5 years to 2 years. So the surprising part of the conclusion is how ordinary this is for nearly everybody. We'll be going into a lot of other ways that people have damaged themselves, not just through medications, but through other things that are more self-inflicted. But I thought the discipline of going through this and getting into the labs will really lay down a foundation of further understanding the importance of IGF in your life and in your labs. We'll talk about other labs as well, okay? So more to come. Here we go. This was the last week's video, part one. So if you didn't see it, it really would be worth you watching this now, because I laid down things I'm not going to be repeating. I think it's unfair to the people that are already seen part one to keep on repeating all this stuff, okay? But it's a great video, getting a lot of good press so far, and thought you might enjoy it if you haven't seen it so far. Part two, now an entirely different context we'll be going into to compare the results of these two people. IGF, we've talked about that. That's going to be the theme through all of this. Fasting glucose and insulin, so it has to do with metabolic health. Lipid panel, otherwise known as your cholesterol panel, right? Your total cholesterol, LDL, HDL, triglycerides, and glucagon. Look at their cholesterol levels specifically. So what I did, and this is just a common age and cholesterol panel that I put out, and I showed it in the last video as well. So we have versus age and versus IGF. So we have, this is total cholesterol over here. This is all the cholesterols together, total cholesterol, LDL, and HDL versus age. And notice that over the age, this is my population of the people that I've worked with. So it's my data, if you will say. Not so much my data, but the data that is collectively put together from the people that I've worked with, as opposed to a public research out there. So we have HDL doesn't change that much through our lives. You go, yeah, it was down, then it's up. It's true. But relative to the others, relative to LDL, which clearly ascends through lifetime, and this is total cholesterol, ascends through a lifetime from age 15 to 80. I have yet to update another 20 people to put in. It could have gone up to 88, but you get the pattern. The pattern probably won't be changed that much. But what's interesting here is this. So the recommendation is that anybody over 200 for total cholesterol should be put on a statin. So given my data, which I think represented that any doctor, this would be replicated in any doctor's office, family practice, what they call internal medicine now, throw it together, they could do it in a week and go, oh my gosh, this is true. It's not actually, oh my gosh, this is true. This is, oh my gosh, this is true 60 years ago. And it's still true now. But it says the average age relative to my population is 35. So anybody over 35 is probably going to have a total cholesterol over 200. That means this is the market for statins. Pretty good. Anybody over 35 to 85, that's a 50-year market. But let's say, no, we're not going to use total cholesterol as the prescribing tripwire here. We're going to use LDL. So LDL is anybody over 100, it should be on a statin. Well, LDL, the average population, male and females, crosses over 100 at even a younger age. That would be 20. They go, well, that's a bigger market. There's another 10 years we added to the market. So I'm being a bit facetious, but I'm being true with the numbers, okay? So total LDL, total cholesterol, and LDL cholesterol increase with age. And I'm hoping you already knew that because I've covered it in a number of videos. So this graph here is the same one there. I've just put total cholesterol in its own little panel here to see it a little more clearly. Oh my gosh, right? We're going to be drilling into this a little bit. So here we go with what you just saw of, now I did straight line as opposed to what's called polynomial. HDL, LDL, total cholesterol. It's a little easier. Here's the 88-year-old woman that I added to, this was a while back. Somebody said, you know, my mother's 88 and she's been told she should go on a statin. Can you imagine that? Somebody who's 88, you ought to go into a statin lady. So I said, what are her numbers? Can you get your numbers? I'll throw them to my graph and see if she's off. She was spot on. She was exactly where she should be. So if you mark this whole thing out, she was right there, right there. So a friend asked about his 88-year-old mother's cholesterol levels. I plugged in her results into the age cholesterol scatter plot, which I would suggest you do too. Use this as a tool. This is such a great tool. In age cholesterol, when you got your numbers, throw it in. Where are you? If they're off a lot, suspect something. But more than likely, you're going to be relieved by saying, you know, I'm normal. You bet. Anyways, her results fit like a hand in glove. But wait, cholesterol levels were much higher than expected for the two people we've been following in the story. Here's a female, 65. So remember, from 63 to 65, they went on a ACE inhibitor. She went on an ACE inhibitor. He went on an ARB, which is an angiotensin receptor blocker, but basically the same thing. Okay? But so I threw them in. First thing I did, I took their cholesterol levels from the panel that I did on them, and their levels were a lot higher. So their HDL is a good, you go, well, it's good to have HDL, isn't it? I would say yes. So when I saw this, I'm thinking, that's fine. 125, I've never seen anybody have 125 for their HDL. Mine's consistently over 100, not 125. So I go, well, that's interesting. And for their LDL, it should be down around here, about 150 or so, accordingly. They're at 216 and 255. And then for their total, really interesting, look how close their numbers are. 354 for her, female, 65, and 345 for him. So to that background, let's add these two people's results. They're even higher than expected. Something is going on here. So I go, all right, high cholesterol is not a worry for me, but this is higher than high. Remember, total cholesterol, hers, right up here, his here, but this is where they should be. Total cholesterol should be around 280 for age 65. He's 66, 65, so I drew a broader circle. But they're about 350, 70 points higher than expected. What's going on? Do you have an idea what's going on? Both are on ACE inhibitors. She's been on for a year and a half. He's been on for 15 years, taken off and put back on. But now, these are their levels. Before, a year and a half before, I've had lab work from both of them a year and a half before. Hers were down roughly 70 points. His was down 60 points. That's amazing. Okay, so I go, all right, maybe we're onto something, the before and after. It's lucky to have before and after. One was for my labs in both cases. The other were other labs that she had done that she forwarded to me. So something's going on. It's nice to graph this because it's a common lab. Now let's do something a little bit different. Let's graph IGF, insulin-like growth factor, -1, I'm just going to call it IGF, to total cholesterol. This is my scatter plot of these two variables, just two variables, total cholesterol, scatter plot, IGF. Now IGF, as I mentioned before, as we get older, it does decline. I've shown that a lot, and we'll come back to that by the end of this video. So we're going that way in terms of life, but they went that way a lot faster than they had to. So in other words, it accelerated their aging. She went from, they should both be around in the area of 140. She is, here we go, total cholesterol is what they're doing right now. Hers is now 55, his is 75. Here's his 75, it should be there. Hers is 55. She's so low, both in terms of IGF, that she's way over. Look, so when you do IGF at 55, so I had to pull it down here so you could see it, 55, and her cholesterol is way up here, so the pin, if you will, the mark is way up here. What is happening? Well, when IGF drops down, your body tries to compensate by increasing glucagon. We'll get to that in a second. That was a kind of a spoiler. So the point here, as IGF decreases, total cholesterol increases. And why is that? Why does total cholesterol increase as glucagon decreases? 2 years before, it was a different story. So with hers, this is where she was, 286 to 354. That's a big change, over 70 points. His was 283, and really interesting, their befores are very neck and neck, their afters are very neck and neck, almost identical if you ask me. So her IGF before was 143, and she dropped to 55. His before IGF was 100, changed to 75, and this is where their marks were way over here. So their cholesterol, really interesting when you see the graph. As you decrease in IGF going this way, natural or unnatural, whether you're just getting older or you're doing something to force your IGF down, like they are, it is going to force your total cholesterol up. So now we have a reason. So here we go. Before was this and this, they're 3 points apart. That's amazing. And after, they're just 9 points apart? Yeah, they're 9 points apart. There they go. Before and after was dramatic. 143 to 55, 100 to 75. After 1.5 years, after 15 years on and off. Length of time on ACE inhibitor, or ARB. Now look at their glucagon levels by age and then by IGF. So let me explain this. So this is age, age, IGF for the bottom. So we're doing age versus IGF. I just said as we get older, that amount drops down. Makes sense. Here's 15 over here, 80 over here. We see our IGF drops down. LabCorp and all the other labs have their same similar levels. So what we have is at age 67, 66, where they are as a generality, they should be around 110, according to my data. They should be around 110, but they aren't, of course. Now let's do age versus glucagon. Well, their age, around 65, 66, 67 in there, it should be around 45 to 50. Remember that. Should be here 45 to 50. That's the nice thing about these age versus age plots. Now that's where their glucagon should be. Now let's put that number, 45 to 55, on the IGF to glucagon. So this is where they should be here, and it shows that, again, their IGF should be about 110. So now we know that by doing this, we've boxed it, and we know the number they should be at by IGF, and they're a long shot from that. So now I have a frame of reference, which I wouldn't have had before, because when you go and get your labs done, as I showed you in the various video before, they don't have, only IGF has an age-specific changing reference rates. Others are, you got to be in the box, got to be in the box, got to be in the box. Well, this is now age-specific, where their IGF should be relative to my data. So now it narrows it in, makes it kind of personal. So glucagon, what does glucagon do? Glucagon is kind of the opposite of insulin. It does a number of things, sort of worth going into that, but a little bit, but we're just going to say what it does. When you're fasting, for instance, your glucagon goes up. What does your glucagon do? It wakes up your liver, and it tells your liver, make sugar, make glucose specifically. So that's gluconeogenesis. It says make energy. We need some energy. Make it, make it, make it. It forces it, your liver. So it forces gluconeogenesis to the liver. That's one of the functions. That's kind of the key function. So it always happens throughout the day a little bit. You get a little bit of that effect even when you're not fasting. But when you are fasting, it's pretty much the hormone that's going to make you survive, glucagon. So IGF, as it gets lower, as these guys will show, there's their spots here. They've moved way down over here. Their glucagon clearly has risen. All right, so the question becomes, what happened? So here we have glucagon. I didn't have her before glucagon, so I'm guessing what that is, but I had his. His was obviously lower, so he was further down. It looks a little busy, but it goes this way. His glucagon before was here, right? So his glucagon was here. This is his IGF. We know it was 100, 136, but it went from 36 to 60. It follows the trend perfectly. She was, in terms of IGF, 143 all the way, pretty much a 100-point fall, 90-point fall. So we're saying that it should be in the neighborhood 140 is where it should be, and that's probably where it was. But you can see that it certainly corrected itself. Now they're pushing it. It's really all on glucagon. Something is blocking their IGF and is making their glucagon, trying to keep them alive, if you will. But it also is going to affect other things. Glucagon, well, I'll let you see that in a second. So we have glucagon. Here's from their labs. They're 94. We don't know what hers was. His was 60 to 36. And their IGF 50 to 143 to 55, 100 to 75. You saw this before? There's a total cholesterol, and here is total cholesterol versus glucagon. So what do we know? We know that glucagon increased. What happens when it increases? Well, it increases, it forces your total cholesterol to go up. So this is what we're seeing. We're seeing that your glucagon is trying to make this couple survive, that is, increase their cholesterol. So glucagon, now we're at the glucagon. Again, the glucagon to cholesterol. But now we're going to go over to thyroid, which we talked a lot about in the first video. What we found about total cholesterol and thyroid, one of the common things with thyroid is people who are hyperthyroid, not saying they are, but they're headed in that direction. When people are hyperthyroid, they have high cholesterol. So 3 things that are associated with hyperthyroidism as one of those things you had to memorize in medical school were elevated cholesterol, constipation, and fatigue. And usually the patient will complain about fatigue, and that's what will make the doctor order, their doctor order a thyroid panel. So here you go. But what do we find out is that as our cholesterol goes up, if you will, our T3 is falling. In fact, it's probably because of the T3 is falling, as we've talked about before. These guys have low T3. Because the T3 is falling, TSH, thyroid, so definition of hypothyroidism, thyroid stimulating hormone, increases, and they become hypercholesterolemic. T4 doesn't change that much. So what we're saying is the conversion of T4 to T3 is happening less and less and less. Now look at aging collectively, how their medication accelerated their aging. What our labs show us about getting older and how to use this information to age well. So one of the things I would use from this video, if I were just watching it, I would screenshot some of these age reference charts and use them for yourself and throw your numbers on it. I'm not saying they're gospel, but I think if every doctor did this, you would probably have the same graph. Exactly? Pretty close. You know, it's for humans. And relative to this, we're all different though. So I would use that and then throw your own numbers in, then you get to see where you are. Okay, so my gist of all these videos is you need to take care of you. If you're going to outsource it to some doctor and have them call you when they find something wrong, you got to figure out what to do with it. You got to figure out what it means and how you're going to change your course if you need to. All right, so we talked about T3, T4 versus age. There's what that looks like, which is the ratio of free T3 and free T4. Here's the ratio of IGF and age. We've talked a lot about that. Here's the big picture of thyroid, of TSH, T4, T3, and all T3, T4 ratio. So you can see that with age, our T3 comes down, our ratio obviously changes, our TSH goes up to try to compensate, and our T4 really doesn't change that much. All right, now here's the cholesterol panel. That would be golden. You should use this one, plug in your own data and see where you stand. But it's one of the things I use on everybody. So glucagon. Glucagon goes up as we age. And why does it go up as we age? It goes up as we age for a number of reasons. Primary reason is because the IGF goes down, right? So the IGF is always the opposite of it decreases in life and certain things have to increase to compensate for it. So here you have almost a mirror image, glucagon to IGF. I know some of you go, I don't know anything about this and so on and so forth. How will I get this? I'll show you that in the end. Don't worry about it. So back to them, IGF. You've seen this again. They changed a lot, right? This is their new numbers, 55 and 75, and this is what they are. Even when we just use those numbers and I put them on my graph, they go, they're below the graph. Something is going on. They're nowhere near the graph. They're below the graph, and so it makes me think I need to dig and find out what's going on. All right, now here they are on the glucagon one, as we've talked about. Where are their numbers? 65 and 66. She's way up here. And he's there. She's way up. She's really trying to compensate. Her age versus glucagon is really screaming high. We don't know what it was before, but it's high. Way off the chart, something's going on. His is moderately. If I just saw this number by itself, I go, pretty close, not so much. But where it was, the change is what drew my attention. All right, going deeper on these labs. Glucose. So we're going to look at glucose and age. This is called a polynomial chart as opposed to a straight line. Sometimes when you go through and you make these scatter plots, and I love scatter plots because scatter plots are like putting on your glasses. So when you go from just looking at labs, like we showed you in the last video, and you then do spreadsheets, that's kind of like putting on one power of your glasses. When you go from your spreadsheet to making charts, scatter plots, like you've been seeing all along, it's really like putting on an even more powerful glasses. It really allows me to see what's going on. So anyways, age versus glucose, what do we say? Notice, this will be my loose interpretation, from age about 30 to age about 65, it's roughly the same. You can say a little higher, then it goes down, and I would say you have a plateau of about 35 years. Here's insulin over age. Insulin decreases. Insulin resistance, HOMA-IR, we can get into that a little more, that decreases with age. So our insulin sensitivity or our insulin resistance decreases generally as a population. Now there's exceptions, and we're going to look at that. So we're going deeper on insulin a little bit. You need to know both the relevance of scatter plots and how they're really making you understand all these various labs, or just looking at these three different labs. So all right, insulin per gender, right? So we just looked at insulin per age. We looked at, I don't think we've looked at insulin per IGF, but insulin per age is right here. So we just looked at, so all people, so everybody in the data, this is what it goes down over age. But if we break it out by gender, women and men, and then look at age, what does it look like? Insulin actually goes up with age for women, goes down for age for men. Of my data, I always qualify everything to say my data. I think that the world would agree to my data, but let's let the world do that when it happens. So that's interesting. So you can't just always look at all people, this is what happens. And that's why I always get so peeved when there's a one size fits all. Well, we all respond this way. Well, I actually just sort of led you into believing that all people respond this way. With age, our insulin goes down. And now I said, we have to look a little more clearly. This is what happens. And I'm going to do one more step as well. Okay, so now insulin per age per insulin resistance. So we're going to dig into insulin resistance a little bit so you understand that really well, because it's a profound difference when we break out these groups. Okay, so we have insulin, right? Insulin per age. We've seen that 2 or 3 times. Insulin per age, insulin per age. But here's the big one that I said, hey, everybody, their insulin goes down with age. That's what happens. And I just said, hey, men and women, oh, it's actually different. Oops. Now there's another little way of looking at it, not men and women, but insulin resistant people, regardless of gender, and non-insulin resistant people. So the non-insulin resistant people are those who have HOMA-IR under 1.5, no more than 1.4. And so you have basically a healthier group versus a less healthy group. You'll know more about that in a second. But anyway, what I wanted to show you is insulin resistant people, with age, their insulin goes up. Whereas the non-insulin resistant people by HOMA-IR, remember they're under 1.5, is that for the most part, it doesn't change much at all. I mean, I could have blown up this chart and you can see that it does increase, but it's a slight bow. It kind of looks like T4, doesn't it? And it really doesn't change that much. Here, unequivocally, it goes up. What am I talking about? So what is HOMA-IR specifically? The standard used for addressing insulin resistance. So when people say they're insulin resistant, it's not a general sort of vague term. It's a very specific lab, empirical lab. So it's called HOMA-IR, and the HOMA stands for homeostasis model assessment of insulin resistance. HOMA-IR equals fasting insulin. Don't worry about it. I'm saying it's a real formula. You don't have to memorize it. We're not going to get that complicated. But I want you to know it's a real thing. It can be figured out. You can figure it out on the back of a napkin, or you can, I'll show you where else you can figure this out. It's fasting insulin times fasting glucose divided by 22.5. It was developed by a group of people actually over at Cambridge University in the UK. And so anything over 1.4 of that formula is considered insulin resistance. Okay, let's get on with it. Here's the other place you can just simply go online at that link, plug in your numbers of fasting insulin and fasting glucose, and it will give you a number. And there you go. So now you know everything I know. So now let me go back to the spreadsheet and say, let's do this. Let's just take the spreadsheet, and I have a lot more people than this, but this is a small group of people, so the numbers can be big enough to be read, right, by you and me. And so we can have this conversation. So what I did is I squished down the spreadsheet. I'm just going to look at this. And I said, let's first reference everything by glucose. So glucose, low versus high of this group of people. What is it, 15 people? Maybe 20? I don't think it's 20. So from low to high, and everybody who's in the solid green bars, that's an okay number. That's an okay number. And anything over that is considered too high. Too high. Bad girl, bad boy. And so then after that, after we did that, we're going to look at cholesterol. So this is sorted by glucose, and then we're going to look at cholesterol, and we could look at other things. We could look at IGF relative to, right? So everything's been sorted here. We'll get into it. But here's HOMA-IR down there. HOMA-IR, just let that fall where it was, but it wasn't always correlated with the glucose level. Interesting, huh? But first, let's view collectively cholesterol versus glucose. Cholesterol versus glucose, those two. So total cholesterol range is less than 200. It's less than 200. Okay, so let's look at these are all the people, right? All the people, and now we're looking at glucose. This is a glucose range of low of 55 and high of 110. And so what I did, I put in the range, the recommended range. This is by conventional. When you go to the labs, you're going to say it says 65 to 99. So I threw that up here on the glucose level. So anything in here is a normal glucose level. Well, according to my data, you're not going to have a healthy cholesterol, total cholesterol level until your glucose gets to be roughly 180. Oops! If your glucose is 180, you've got a lot of other problems. But what this shows you is that if you have severe metabolic dysfunction, primarily fatty liver, eventually your total cholesterol looks good, but it looks good for a bad reason. There you go. I want you to know that. There you go. That's a reality. Now look at total cholesterol versus glucose separated by insulin resistance, right? We're going to have insulin resistant group and a non-insulin resistant group based on the HOMA-IR number, right? So the non-insulin resistant group, total cholesterol, you know this number, under 200. Non-insulin resistance, now I made it a little easier to read. Excuse the 69, I got so dizzy with doing these numbers. It should be 65, but it says 60. There you go. So it should be a little bit over there, right? But you get the point. and there's your 200. So what it's saying here for the healthy people, what it finds is as their glucose rises, for healthy people, for non-insulin resistant people, as their glucose rises, fasting glucose, their total cholesterol rises. So glucose goes up, total cholesterol goes up. That's not much different than glucagon goes up and total cholesterol goes up. Glucagon makes the liver make glucose. So however you get the higher glucose, your total cholesterol is going to go up. So comparing non-insulin resistance to insulin resistance, what we find as the glucose increases with insulin resistant people, their cholesterol falls. So you go, wait a minute, more glucose makes for a better insulin? These are basically a continuation of the same graph. What this is showing is that these people are getting sicker and sicker. Metabolically, their liver is getting metabolically more and more dysfunctional. And so what that means is that they're getting more fatty liver, and their liver cannot push out the fat, i.e. the cholesterol, into the bloodstream. And so that it looks like a good lab. You go, oh, well, your cholesterol is great. Your LDLs and total cholesterols are great. What it really means is that they don't look at other markers, like your triglycerides over HDL and so on and so forth, that you're fasting insulin for one, that you are getting a dysfunctional liver. So this is a bad liver, it's dying right here, and that's why we're saying, well, here's the healthy range for glucose, and you're going, all right, the only people that have total cholesterol in the high 250s have healthy glucose, but as their cholesterol gets better, as their glucose gets higher, it simply shows that their liver's dying. So it can be misconstrued. So insulin resistant people, basically, as you get more, higher and higher, because they're diabetic at this point, higher and higher glucose, the total cholesterol drops because the liver can't get it out of the liver. So the point is this, you got to be careful about how you interpret scatter plots. If you know the context they're talking about, it's very helpful. If you don't, it can give you wrong information. I thought this was funny. Every single person who confuses correlation and causation ends up dead. There's a number of levels to this. One is showing a correlation. It's showing an example of a misinterpretation, but the bigger point is actually partially true. Those who misunderstand correlation, these two things are correlating with each other, doesn't mean one's causing the other. You have to identify that relationship. So what I put in here was you have to be careful about how you interpret scatter plots. Scatter plots can be wonderfully predictive if the data is accurate. That's why I trust it with my data. My data is real. When I look into research and so on and so forth, there's so much propaganda in research now. I go, I don't know about this. I think they're pushing an agenda and making the numbers fit with the agenda. With me, I'm saying, can you show me if this statement's true by looking at my data? All right, insulin per age and insulin resistance. Now we're going to break it down. Look at this. Have you seen this 3 times? Insulin, I just said, hey, it decreases. Insulin decreases with age. Seen that 3 times. And I said, hey, well, it's different for women and different for men. Huh? Now I'm saying it's different for insulin resistant people. Look at that. For insulin resistant people over HOMA-IR 1.4, it shows that it increases, but it kind of has a plateau from 30 to 65. So for 35 years, they're insulin resistant, but their insulin is staying about the same. Right? So this is insulin versus age. The insulin stays about the same. That's our working period. And after 65, it all goes to poop. Here we go, insulin versus age with non-insulin people. What we find is it's 15, by the way, from age 15 to 80, is that, yeah, it rises a little bit, but it rises to that's 3 to 5, it peaks at 5 and goes down. So roughly very little change, but it does rise from 30 to 65 for that same area, but very little. Here it rises, plateaus, and keeps on rising. So this is from the CDC, and I decided to make a image of what they call a pig in the python. Are we seeing a coming trend? Are we seeing a population that is getting fatty liver? Are we seeing a population that's obese? Are we seeing a population that is insulin challenged, glucose challenged for a lot of reasons, not just carbs? Going through in the python would be age, from young to middle age to older. And so I looked at the CDC, and adults between the ages of 40 and 59 are more likely to have obesity. In fact, this is the United States. And in fact, more than 44% of adults between these ages have obesity. Meanwhile, obesity affects 39.8% of adults. And you can see that down here. So how do I interpret this? I go, all right, there is a bulge in the middle, but it's not that big of a difference between those who are younger and those who are older. I think the edge of the python, if you will, edge of the peak in the python is probably older. And if you were to go from 70 to 80 or 80 to 90, you'd probably say it would be a big difference. So there is that's going on. So when you see this data, you have to ask those questions. What is the correlation? What are we correlating here? All right, so back to our story. I didn't forget them. There was a point to be made. Slightly bigger picture. There's their gender, age, glucose, insulin, HOMA-IR, this is their data, IGF, and glucagon. Here's where they are right now. I've read this to you. And so here's, I didn't tell you what their HOMA-IR is. Their HOMA-IR right now is she's 1.5, so she can be called insulin resistant. He's 1.4. He's right at the edge, right? Perhaps it was a good day for him, and he's not. On a bad day, he is. So that's where they are right now today, or within a month or two ago. And their IGF was low. We've talked about that a lot. Their glucagon, we've gone through that. But watch this. See what happens. Now we add in the before years. Let's go right to the middle of it. HOMA-IR. We want under 1.4. Remember, she is insulin resistant. She was nowhere near insulin resistant a year and a half ago. He is 1.4, borderline insulin resistance. He was 0.6, nowhere near it a year and a half, 2 years ago. That's a big difference. What else? Their insulin went from hers went from, call it 3, 2.9 to almost 7. Huge difference. She's not diabetic, of course, but she's insulin resistant. He went from 2.7, even a better number, to 5.7. They both went up. His glucose went up 14 points. Her glucose actually stayed the same. This doesn't always correlate, as we've seen before in the labs and the spreadsheets, that increasing glucose doesn't happen until your liver's out of control. So you can kind of have normal numbers. If you're not taking your insulin lab, I don't mean taking it as an injection. If you're not tracking your insulin, you don't know what your liver is doing. So your insulin is really important to take together with your fasting glucose. Here's IGF. We've talked about that since the cows come home. It dropped. It dropped a lot for her, a little for him. The second, glucagon, is pretty high for her. We don't know what she was before. He almost doubled. Right? So he went up by 24 points. That's a lot. And there's their glucose. We've talked about that. So what changed? Remember, he was taking it for 3 months. He was off and then came back on. All right, glucagon, we've seen this a number of times. IGF has decreased. The glucagon has bounced up. We talked about that. Remember, that's the number they should be at, but they're way over that. Okay, glucagon. So what the question becomes is, what the heck happened? We're looking for the IGF and glucagon. So before, her IGF was 143 to 55, and her numbers shot up. She went from, we don't know what it was before, we think it was down here, if it's correlated. So she went from about here, way up there, right up the curve. And he went not as far, but he certainly went on the same pattern up that way. So how does all of this happen? Let's put all of this together. What we've learned, we can chase lab after lab, but there's a story here, and this is the point. This is the end of the story now. The end of the story says this. If you look at the glucagon versus glucose, the insulin versus glucose, the HOMA-IR versus insulin, they all increase, okay? Increase with glucose, increase with glucose, and obviously increase with insulin, HOMA-IR. So here's how I think it went. Your IGF was decreased, and it forced your glucagon to increase, which led to an increase of glucose, right? Went to the liver, gluconeogenesis, which leads to an increase of insulin, trying to keep that glucose under control. The increase in insulin led to an increase in HOMA-IR, which is the same as an increase in insulin resistance. So back to where we started. This is the LabCorp range for IGF. Here's where he was. Here's where he contracted to. So that's a big difference. From 100 to 75, he went from 15 years on an ACE inhibitor, he's taken off, went back on for 3 months. So in 2 years, he went from low to very low. She, on the other hand, was on for a year and a half. She went from a high to a low, you know that. That's a big change. But what does it look like? Here we go. She went from high normal, a really healthy high normal, to below normal on the LabCorp numbers. And there's the age versus IGF. We've seen that again and again and again. What difference does this make? What difference does it make? All right, it's an interesting conversation, but what difference does it make? It's got to be relevant. It is very relevant. This is the critical hormone. This is the critical lab that you should start learning about and know about. How can I sell it to you? I'm trying to sell you on you. Am I doing okay? This drop in their IGF, here's the age that they were at, 63 to 65. It was 143, she went to 55. That's the equivalent age on the LabCorp range to 90. He went at age 65 from 100 to 75, which is a LabCorp age of 78. She increased by what, 27 years? and he increased by, quick math, 13 years. That's something. All right, what's the big deal? So this all comes together in the very big topic I'll call chronic diseases of civilization. What has happened in the last 60 years? And just don't tell me it's a linolenic acid and everything else. That's part of the story. We're going to come back to that relative to IGF for a whole separate video. Not going to talk about it here. But it comes down to this. I'm oversimplifying to keep it pretty clean, but this is what we're talking about. When you don't have enough IGF, you atrophy. What does that mean? Dementia, sarcopenia, osteoporosis, to name a few. When you have too many, and this is far less documented, as we'll see in a second, but I'll be doing other videos on this to really show you some interesting correlations. When you have too much, they'll say it's uncontrolled growth. That's the bottom line, and that's what people say. We're going to dig into that a lot. I'm just going to leave that there as that. Uncontrolled growth is cancer. And if you have too much IGF, boom. I think it's more of a degree of reverse causation, but it's worth its own topic and a lot more documentation than that. Too much, uncontrolled growth, cancers. The right amount means neurological maintenance, neurogenesis. You keep your neurons, brains, health, arms continuing, cell survival, all these fancy words, myelinization, should you need to know, which means then you have brain health, decreased dementia, you have muscle, decreased sarcopenia, you have good bones, decreased osteoporosis, you have healthy aging. So too much, Dr. Jekyll and Hyde, and that wasn't my analogy. Great, isn't it though? That came from this study called 40 Years of IGF, the Jekyll and Hyde of the aging brain. That was nice. So there again, you just saw that. Great concept, a tad oversimplification, but at least it puts it on something you can understand, and we'll elaborate on it. I think it needs to be elaborated on it because I do believe that IGF is very important to follow, and it's not that expensive and it's not that complicated. You need to track your numbers to the degree you care. If you want to look into the data of that particular publication, it was a really good one. So the details of that study, because I just want to throw that out to you, it came from the UK Biobank. It's a population-based study. This was really cool. 500,000 individuals from the UK provided a baseline measurement at recruitment between 2006 and 2010 and followed their participants prospectively through the integration of the national health records. In other words, as they came in, they go, all right, age, height, weight, all the age, height, and weight, and blood work, and if they had any diagnosis at the time, they put that down. So that's what they did. That's a lot of people. It took a couple of years, apparently, to go through this whole sort of system. But at baseline, participants underwent phlebotomy, blood draws, lab work, physical measurements, provided medical history, and demographic information. And this is where you can go for that. It's called the antagonistic pleiotrophy of insulin-like growth factor. And it was actually an American study done about the data because the data was just too golden not to use. It's kind of like the NHANES studies in the United States. So this is what they came up with. I used this from the last video, and this is how they prioritized it. The number one correlation they made, and these are scatter plots, by the way. And so look at how tight that scatter plot is. Point one would be a straight line, would be, it increases or decreases. A correlation would be absolutely 100%. This is 98.7. To me, that's about 100%. So their highest correlation to decreased IGF was osteoporosis. Number two was diabetes. That's still very high. Number three was vascular disease. These kind of overlap if you know about diabetes, vascular issues. Number four was death, period, by any cause. The fourth hardest was death by any cause. Five was dementia. Six now was cancer, they're saying, but the correlation isn't as high. Do you see how that is? Interesting. We'll come back to that. It's all about IGF. So this was covered on that video, which is a couple of videos ago. You need to set the foundation. I really hope you look into this and take care of yourself and you start tracking and being your own wisest person. I'm not saying to discard what your doctors are doing, but if you're at the point of this is my doctor's responsibility, we don't have time to take care of everybody. That's my point. You take care of you. So gradually start to know what you need about labs. Labs are the way out. It's real information we can talk about. It's not a one-size-fits-all. Well, should I do this? Well, should I do that? When people ask these questions, I don't know your labs. I don't know who you are. I'll end with this. IGF. You have to know what your IGF numbers are. These are my age scatter plots. This is from LabCorp. It's time to find out, don't you think? So what can you do with this information? Get your labs checked. So I just priced them out by what I call Ulta Labs, and I'll show you the link for that. I don't get a penny of it. Yeah, believe me or don't believe me, I really don't care. But I price them out because it's where I started using and recommending people to go for their own free labs. You engage yourself. So what would these labs cost? Because somebody posted in one of my past videos like, oh, these are labs just for rich people. If you can't afford some of these labs, you don't care enough about yourself, is my answer to that. One lab is relatively expensive, and that's glucagon. And I'm lucky I have the volume of data on that. So outside of glucagon, all these are pretty darn. IGF, $58. Fasting and glucose and insulin. Actually, that's 2 tests. You could use that twice, $30. There's a phlebotomy fee, which is usually $8 to $10. And these prices vary across the country. So if you're in New Mexico, Flagstaff, New Mexico, I don't know what it's going to cost you. It should be about this, right? If you're in Tulsa, Oklahoma, about this, but it's going to vary, okay? But it's not going to vary by much. What I'm saying, it's fairly cheap and it is doable. You go do it on yourself and you learn why these are valuable. That's my point. Thyroid panel, lipid panel, all the cholesterol. $9, that's a steal. So in the very least, you can compare your results to the age graphs in this video for those labs. Track them year after year and learn what they mean. So what is the metabolic cost of all of that I've just told you about? And I'm going to summarize it. Of the ACE inhibitors and the ARBs, it will decrease your IGF and your free T3. That was the last video. Total and LDL cholesterol will go up. That happens in life, but it goes up even higher due to increasing glucagon, leading to increased glucose, which leads to ... Insulin resistance, HOMA-IR, starting and gets worse and worse. You can change all that. Don't let another side effect be the downfall of your vitality for the rest of your life. Know your IGF lab values and change your life. Here's the Ulta Lab tests. That's where you can go. There's the link. You get it through, that's Keto Naturopath, that's us. I don't get a penny from it. If you have your own place to do it, go do it. But I'm asking you to go do it. I'm motivating you to go do it. Learn about these things. It's important. I believe it's important. So if this is something that you're interested in, that is a topic that I obviously go deeper in terms of labs, in terms of how to do it, in terms of why you would want to do it, various topics that you've seen that I've done in the past, then please let me know below in a comment. Till then.